Good evening, everybody. As I welcome you to East Intervention Chronicles Series 1, I'm Dr. Binayak Dev at R&W Hospital in Kolkata. I'll be moderating the session. We have on expert panel Dr. Prashant Kumar, who is Assistant Professor at Rajendra Institute of Medical Sciences, Ranchi, since June 2018, and he has special interest in bifurcation stenting. We have three speakers in the form of Dr. Ayesha Kadir from Dhaka, Bangladesh. We have Dr. Soman Saad Behra from Apollo Hospital, Bhubaneswar, and Dr. Dhananjay Kumar. He is from Sasaram, Bihar. So today's topics will be three, and we'll have speaking for 10 minutes with a discussion of about 5 minutes each. And the interest is that as we move along to 2021, after a year and a half of hiatus during the COVID, we're kind of getting back to our work schedule slowly, but the offline conferences are still out of limits. We are still online on the conferences, on the meetings, and we have learned a lot in the last 1.5 years through these online meetings. So hopefully today's topics which we have are pretty of a lot of interest, and I hope that our viewers will enjoy the meeting. But with that, let me introduce Dr. Ayesha Kadir, who is an very eminent cardiologist in interventional cardiology, from an assistant professor of cardiology at Ibrahim Cardiac Hospital and Research Institute at Dhaka, Bangladesh. She has research interests in cardiovascular clinical trials, population health, and outcomes in acute coronary syndromes and coronary intervention, and is undertaking a part-time MSc in clinical trials at the University of Oxford. Dr. Kadir is a social media editor of European Heart Journal Case Reports, also a member of SKY's Women in Innovation Committee, and serves on the AH's Council on Clinical Cardiology Leadership Committee. She'd be discussing a case of double jeopardy in interventional cardiology. As if one jeopardy is not enough, she's talking about or discussing a case or showing us a case of a double jeopardy. So really looking forward to Dr. Ayesha Kadir's presentation. Over to you, Dr. Kadir.
Thank you. Thank you so much, Dr. Deb, for that very kind introduction and for the opportunity to speak today. I'll just share my slides. I put them up. Can you see them?
Yeah, I can see them.
Okay, great. So let me start. As Dr. Deb said, it's a case of double jeopardy, and I'd like to acknowledge my mentor, Professor Saidur Rahman Khan, for his role in this case as the main operator. So our patient was a 34-year-old young gentleman who presented with ACS. He was hypertensive and dyslipidemic, and he came with chest pain for 5 hours to an outside hospital where he was diagnosed with an inferior STEMI and thrombolized there with tenecteplase. And then he was referred to our PCI-capable center within 36 hours for further management. When we came here, we found an ECG that was consistent with an inferior MI with Q in the inferior leads. He also had some STT changes in the anterior leads, and a good enough ejection fraction of around 50%, which was well preserved. So we went for coronary angiography after he was COVID negative. This was a COVID era case. And this was the left system. We did not expect this in this 34-year-old young gentleman. We were looking for a straightforward lesion in the right system. So we found here he had a CTO of the LAD in its mid part with grade 2 ipsilateral collaterals, epicardial collaterals from the large diagonal, and a CTO segment is then followed by a long segment of diffusely diseased LAD. When we then went for a right shot, which is indeed the infarct-related artery, even this was not very straightforward. We saw that the RCA has a Medina 111 bifurcation lesion at its distal part with plaque burden, and the severity more predominant in the osteoproximal PDA. You can also appreciate some faint retrograde collaterals to the CTO of the LAD. So the situation is a bit complex. It's not really a cherry-picked one. We have to deal with a bifurcation lesion in the distal RCA, which is the culprit, and a null-culprit CTO, which is not really pleasant, even though the JCTO score is not very high, but we always have the unpredictability factor of a CTO that has to be weighed in when we revascularize. And this is really the typical case of a double jeopardy, which by definition is actually the concurrent presence of a non-infarct related artery CTO, that is a bystander CTO, which in our case is the LAD, in a patient who presents with an acute MI where a newly occlusive infarct related artery, where in our case is the RCA, might supply collaterals to the CTO, resulting in a larger area of subtended myocardium. And this scenario is seen in about 7 to 13% of patients who present with mortality and morbidity. But of course, the exception here is that in our case, the infarct-related artery is not occluded. So this is not strictly a primary PCI, but indeed a pharmacoinvasive PCI. And additionally, the ischemic burden of the left system is partially relieved because the patient already had ipsilateral collaterals from the diagonal. But we need to consider complete revascularization. And this type of patient, the most robust data comes from the EXPLORE trial, where they found no benefit at 4 months for those who underwent a bystander CTO PCI in addition to the primary PCI versus those who did not, except for this subgroup analysis, where if the bystander CI was if the bystander CTO rather benefit in terms of improved ejection fraction, but that is still a subgroup analysis. So what do? We have here a non-infarct related artery CTO of the LAD. We have a culprit, which is the infarct related artery in the RCA, which is a true bifurcation lesion, but importantly, not occlusive right now because he was thrombolized. And the question of complete revascularization at the same sitting or pre-discharge comes in this case of multivessel disease and CTO LAD. And if so, which vessel to revascularize first? So until a few days ago, we didn't really have data for pharmacoinvasive, but we have just published data from the complete trial for pharmacoinvasive, which also shows benefit for multivessel revascularization. Additionally, the other considerations that we need to weigh in this case, of course, the cost in low-income settings like countries like ours. And this is a pandemic, so there were difficulties in bringing this patient back for a stage procedure. He did not live within the city limits, which is why he was also thrombolized then. We have to consider contrast volume and other procedural aspects like radiation and fluoroscopy time, and importantly, that this infarct-related artery is not occlusive. So in our plan, ideally, if it were a primary PCI, we would go for the infarct-related artery first. But we are seeing no flow-limiting lesion here. There is TIMI3 flow, although it's a complex bifurcation lesion. So we decided to go for the CTO LAD first. The reasons being that, as I said, this is a pharmacoinvasive approach with a TIMI3 flow established in the IRA. And also, a CTO is always unpredictable. Even if there was an unpredictability of whether we could go through the antegrade approach for this, no surety of complete revascularization, and we had to keep the option of CABG as an alternative revascularization strategy in hand. So to proceed for the CTO of the LAD first, this was engaged with a JL guide, and we started with a Fielder XT guide wire with a very small profile balloon support and meticulous manipulation. The wire was advanced through the CTO segment into the distal true lumen. And this was confirmed by an injection. We didn't need a dual injection here because there was such good pristine ipsilateral collaterals. So we confirmed that we were within the lumen here. And we followed that with a short, small balloon inflation with our short, small profile balloon. After this, the IVUS catheter crossed, and we did an IVUS pullback, which showed focal 270-degree calcification along the LAD with long segment disease with a distal reference diameter not greater than 2.25 in this distal segment. And importantly, also, the diagonal ostium was spared. So we decided to keep it simple here, not to go for a bifurcation lesion here, because essentially this is Medina 010. So we didn't stent across as the diagonal ostium was spared. And a long 2.25 40 millimeter drug-eluting stent was placed in the mid LAD. This was followed with a post-dilatation of 2.5 15 millimeter NC balloon and an IVUS pullback, which showed a satisfactory imaging result as well as an angiographic result. So once this was sorted, we then went for the infarct-related artery, which is the distal RCA. We took a 6 French JR guide and 2 workhorse wires, and we went for this because the CTO didn't take very long in terms of procedural time as well as contrast. And of course, the more disangulated lesion was wired. PDA was pre-dilated because that was the more disease segment with a 210 NC balloon. And then we did a pre-stenting IVUS pullback This is a pullback. We did pullbacks from both the PLV as well as the PDA and found that there was indeed plaque burden at the PLV ostium as well. So essentially, this is a Medina 111 bifurcation lesion, which is a true bifurcation lesion. So should we go for a provisional versus upfront? We had to consider that IVUS showed plaque burden in both the ostia, and indeed both the side branches, if you consider here, were good sized. They had least diameter discrepancy, and the PDA ostium had more significant disease, whereas the PLV, which we will consider the distal MB, was larger sized. So among the two stent strategies, we could essentially adapt any of them, in fact, DK crush or culotte, because there was no side branch discrepancy. But considering this anatomy and prioritizing a strategy with the least procedural complexity, we preferred a DK might have been applied since this had the fewer steps. Also, nanocrush is favorable because, as I mentioned, the fewer steps means less fluoroscopy and radiation as well as contrast, and it can be done in all bifurcation angles. So this is what we went for. Both the PLV and PDA were wired with workhorse wires, and we kept a 2.5 15 millimeter drug-eluting stent in the side branch, that is the PDA, and an NC, a small NC balloon, which was sized to the distal reference diameter. The side branch stent was pulled to the inflated main branch balloon, ensuring very minimal protrusion into the main branch, which is really the nano part of this. Then the side branch stent was deployed at nominal pressure, and both balloons were deflated. The side branch balloon was pulled into the main branch so that 50% of it was within the side branch stent, and we inflated this at high pressure so that the side branch ostiums were opened up nicely. Then the side branch stent edge within the main branch was crushed by the main branch balloon, which was again inflated at high pressure. This is the first crush. We followed this with the first kissing balloon inflation using the side branch stent balloon and the main branch balloon at a moderate pressure. Then the side branch wire balloon and the main branch balloon were removed, and the main branch, that is the RCA to PLV, was stented with a 3.5 18 millimeter drug-eluting stent at 14 atmospheres. This was followed by a pot with a 3.5 10 NC balloon at a high pressure. The side branch was then rewired because the pot facilitates rewiring, and also the initial part where we inflated the side branch with the side branch balloon also facilitates rewiring and opening of the side branch ostium. And we followed this with a final kissing balloon inflation at moderate pressure and a final pot with a 410 NC balloon. We did IVUS pullbacks from both the PLV as well as the PDA and found very satisfactory angiographic results and a very nice neocarina there as well with well-opposed stents. So the takeaway points from this second part of the DK nanocrush case is that imaging is crucial to define a bifurcation lesion and to guide decision-making regarding strategies. The key technical challenge in DK nanocrush is positioning the side branch stent before deployment, as I said, the nano segment of it. And there are some advantages to this technique. One of it is less procedural complexity, fewer steps than the regular bifurcation stenting upfront strategies, with good real-world outcomes and favorable hemodynamics. It provides full lesion coverage, can be used in all angles, and the wire in the side branch is never lost before adequate deployment or crushing. The minimal protrusion into the side branch of the side branch stent into the main branch is ensured by nominal inflated main branch balloon, which is one size smaller than the main branch vessel size. And this minimal protrusion ensures that there is very little metal load with minimal neocarina. So this also facilitates easier rewiring through the expanded side branch ostium, and therefore a higher success rate of final kissing balloon inflation. So all these reasons are perhaps why DK nanocrush has perhaps been described as the ultimate refinement of all crush techniques. I would like to thank you for the opportunity to speak today, and thank you for your attention.
Thank you so much, Dr. Aisha. I think it was a wonderful case, and there were plenty of learning points, and I think a lot of discussion points as well. So I'd like to invite Dr. Prashant Kumar, who's our expert panel, to begin the discussion, and then we can join in. Over to you, Dr. Prashant Kumar.
Good evening, everyone.
Good evening.
Nicely done case and well presented. Now, my this was a good decision to handle CTO LED first, because there was TEMI 3 flow in the RCA. So RCA vessel was not compromised. In fact, the LV ejection fraction was normal. So it was a very good decision to go for our LED CTO first before the going in for the RCA. And LED CTO, there was a very good result with the help of IVAS, and there was good match of the distal as well as proximal vessels. Now coming to RCA, I would like to raise one question. Why you go for two stent strategy? I would have gone for single stent strategy, because there was a minimal lesion in the PLV. Definitely ostium of PDA was 90% compromised. There was we would have planned two wire in the PDA and PLV, the dilatation of PDA, and a single stent strategy instead of going for dedicated two stent strategy. What do you think, sir?
Yes, I mean, you were talking about a provisional stenting strategy rather than a dedicated double. I think let Dr. Aisha answer this, and then we can move on to the next question. Yes, Dr. Aisha.
Yes, thank you. That's a very good question, and that is exactly what played in our minds as well. Initially, we were going for a provisional, but when we did imaging and we saw that the PLV had also had significant plaque burden at its ostium, that's when we decided that we would go for an upfront two stent with the least procedural complexity, so that we didn't need to go for a complex procedure like a DK crush or a culotte, and opted for this because it was image guided. I agree, in any other circumstance, or perhaps if it was primary PCI and we had this, we would definitely have just gone for a single stent strategy in and out. But because the circumstances allowed it and imaging dictated it, that is why we went for this procedure.
Okay.
Yeah, one thing, I think there are a couple of very good learning steps from here was that the use of image in a case like this, because the most important part in the CTO part was actually not the crossing the CTO, because as we saw that the JCTO score was just about around 2. So that the diagonal ostium was actually free from disease. That was a very, very important decision. Because otherwise, if you had crossed the diagonal ostium and pulled it to the proximal LED, you were probably in a zone again where you could have compromised the origin of the diagonal ostium of the diagonal. So that was, I think, one of the very good decisions based on imaging. And second, I think, in the decay nano crush, we have to be very, very sure that, when you're pulling back the stent in the side branch, that it is actually not protruding, but you are taking a balloon into the main branch, which is actually giving you an idea where your origin of the stent is in the side branch. So that angiographically needs to be very, very correct. So if that procedure, that part, that step is compromised for any reason, either for the views, I think you need to take a couple of views to make sure that you're in the right position. So that is the most important part of the nano crush, that actually you're not missing the ostium. So nano is good when you've got the ostium and you've got very little stent in the main branch. But otherwise, it could be a miss, and then the whole problem will start. Do you agree, Dr. Prashant and Dr. Adar?
Yeah. Which stent you used in RCA?
Endeavor Resolute.
Endeavor Resolute. Okay. Because I have seen basically in Promus stents, there's missing of the ostium. So in these cases, especially when the artery you are dealing with the osteal lesion, you should avoid the Promus stents.
I think, Dr. Prashant, the next talk is actually about what you're exactly talking. The longitudinal stent deformity where you are actually missing those stent. So Promus stent is one stent, I think, but again, I think when you're pulling back on the side branch stent, that you are actually not missing the ostium should be confirmed with at least 2 or 3 angiographic views. That's the most important part in the DK nano crush, which we can get away with other kind of bifurcation stenting. So just Dr. Kader, I was just wondering, say if this was a primary PCI, just for the sake of debate, what would be a strategy? So the pharmacokinesis, and you had the option of doing the CTO first because you were flow in the TMA3 flow in the infarct-related artery. Say it was actually a primary PCI. Would you tell our students and the viewers exactly what would be a strategy in this case? Would you go for a two-step strategy, or would you do it in the same setting?
So I think if it were a primary PCI with the CTO, the evidence isn't very much in favor of revascularizing the CTO at the same setting. Especially if it were an occluded vessel, we would probably have just done the RCA only. So as we said, the only data for this is from the EXPLORE trial, where the subgroup analysis gives some benefit for CTO-LAD, but a subgroup analysis is just that. It's not the exact randomized evidence. And so I think that's why we were also lucky. The patient was also lucky that he got a complete revascularization in one shot for both the RCA as well as the LAD. So there are clearly benefits to a pharmacoinvasive strategy as well. And especially in our region, I am increasingly, especially after the pandemic, I'm increasingly convinced that it's actually a very good routine strategy for lower middle income settings like ours. It's faster than primary PCI, than arranging it. And also, like, it gives additional benefits like this.
My only concern would be, Dr. Aisha, that if it was a kind of a strategy which you want to tell that it could be one of the routine strategies, that CTOs are quite unpredictable because you have no idea actually what is the length of the CTO and the rest of the stuff, So you probably would spend so much time on the CTO, and then actually the infarct-related artery probably doesn't get that much of time to be dealt with. So I think my strategy would be for any CTO that I study the CTO, plan the CTO, and do the CTO as an elective thing. What about you, Dr. Shant? I mean, do you agree with that?
Definitely. I would have also gone for a single stent strategy with stenting of infarct-related artery. And about CTO, I would have waited for around 4 to 6 weeks and do CTO later on. What do you say, sir?
Yeah, I think Dr. Kader's team has actually done a very good job, but in this particular case, because I think the reasons why the team have done it were very, very good and very substantial reasons. But I think to put it as a strategy for a generalized strategy, I would probably say that the CTO has to be second option after a while, and to do the infarct-related artery first. What do you think, Dr. Kader?
I would agree, yes. Like I said, it's an exceptional case where the circumstances permitted it. Ideally, you should have the infarct-related artery open, and CTOs have to be well-planned elective procedures. But as I said, circumstances, the pandemic, the fact that the patient's hemodynamics allowed it is why we went for this strategy, but probably not to be advised as a routine strategy.
Dr. Aisha,
the reason is actually, Dr.
Yes.
Dr. Aisha, in this case, your team was lucky that the patient has very short segment of CTO. That's why you crossed it in a single attempt.
Exactly. As I said before, the team was lucky, patient was also lucky. There's a lot of luck involved as well.
The other thing, Dr. Aisha, just to to put you on a spot, is that how long would you have tried the CTO if you are not successful? I mean, what you would have done? Would you have gone for a CIBG option, or would you have done the infarct-related artery and gone back for a CTO attempt again?
So I think the reason we went for the CTO first was because we wanted to keep CIBG as an option, because this was not a flow-limiting lesion. So I don't think we would have gone and done the RCA with a difficult CTO that we might have challenges opening up even later. So we would very likely have sent the patient for CIBG if the CTO failed.
Yeah, I think, I'm talking to a group of interventional cardiologists who are, in 2021, when we were trained, and my experience with the Japanese CTO operators, in Singapore, I must say, is that, we used to collect all these failed CTO cases, and these guys used to come for a week and just work on these cases, So those days are kind of behind us, and we are talking to a group of cardiologists who are actually exceptionally good at their job. So thank you very much, Dr. Kadir, for an exceptional job. I would request you to stay for the meeting and put your inputs as well. As I invite Dr. Dhananjay Kumar, who is Associate Professor and Interventional Cardiologist at Narayan Medical College and Hospital, Sasaram, Bihar. And he's talking on a very, very important topic, which just Dr. Prashad mentioned. It is about this stent deformation and its management. As we know that, in the eras of the drug-eluting stents, we have many generations, and as generations went along, the struts became thinner and thinner for good trackability, for good pushability, and so on and so forth. But we had some problems with that. So I think over to you, Dr. Dhananjay Kumar, for your presentation.
Thank you, sir. Good evening, everyone. I would like to request Sachit ji to please share my screen. Yeah. So next slide, Sachit ji. This patient, 66-year male, non-diabetic, non-hypertensive, presented with chest pain of 12 hours. His ECG was suggestive of anterior wall MI, ST segment elevation in V2, V3, and V4. We took him to cath lab immediately. His vital was stable. Next slide, Sachit ji. Next slide. Yeah. Sachit ji. Yeah. Yes. Okay. So before that, I think there will be a RCA shot. Sachit ji. Previous to that. Yeah. So RCA was quite good with minor plaquing in that. Minor plaquing. And next one. Yeah. In left system, the LAD had mid to distal part recanalized, but still significant stenosis of about 70 to 80%, and proximal LCX a discrete significant narrowing. There is no calcium under fluoro in any vessels. So our plan was to stenting the LAD and LCX in same sitting, as both the lesions were quite simple. So we wired the LAD, pre-dilated that, and deployed a 3 into 33 mm Giants Expedition stent and inflated it to the nominal pressure of 10 ATP. We took a 3.25 and 3.25 12 NC balloon and took a boost there before post-dilatation. Next slide. Next slide. Next slide. Next slide. Yeah, this was the wiring shot. Yeah. Next slide. Next slide. Next one. Yeah, we took a stent of 3 into 33. Next slide, Sachit ji. Yeah. So this was the boosted image, and in that, after the first 6 to 8 mm of a stent start, there was a stent deformation. It was appearing like a stent start rupture and over dilatation. We didn't have imaging support to confirm that. Although there was no leak or no perf, and patient was stable hemodynamically, we removed. Next slide. We removed the 12 NC balloon and took a smaller 3 into 8. Yeah. Next one. Next one. Yeah. 3 into 8 NC balloon and post dilated just the proximal part and came out and decided to do LCX plasty later on. Next one. So this was the final outcome from the, yeah. I was in control room explaining his relatives, and within 1 and 2 minutes, patient started chest pain, and this chest pain became quite severe within 5 minutes. We decided to check NGO, and it was in my mind that there is a stent thrombosis there. So I decided for check NGO. Next slide. It was hard to engage the, it was hard to engage. That patient was restless. So took a nearby shot and it appeared like LAD is flowing quite good. There is no stent thrombosis there. So I engaged properly. Next one. Yeah, I engaged it properly, and now the LCX is totally occluded there. So I wired the LCX, dotted it, pre-dilated it, and next slide. Next one. Yeah, next one. So pre-dilated it and deployed it 2.75 into 18 mm Giants expedition stent and came out. Patient was hemodynamically stable. We kept him on tirofiban for next 18 hours. Patient is doing well since last 9 months on ecoaspirin 75, ticagrelor 90 BD, and rosuvastatin 40 milligram. So I would request our seniors to please suggest what else I could have done in this case. In such a situation, I'm just a beginner. I have just completed my DM last year. So I would request my seniors to please guide me. Thank you, sir.
Thank you,
Thank you, sir.
Dr. Dhananjay, for your case. I would ask our expert, Dr. Prashant Kumar, to give his views first. Prashant, you're mute. Can you unmute yourself?
Dr. Dhananjay, you have nicely discussed the case of stent fracture. Now tell me one thing. Tell me one thing. If you would have left the stent as such, what complication you expect?
The proximal end, I have taken 3 into 33 mm stent, and proximal end of the proximal size of the vessel was about 3.25 or something else. So I have to post dilate that at least of the proximal segment. So I decided to keep the that segment as at least the proximal end to dilate up to 3.25. I have not dilated. The stent was not deformed after post dilatation. It was deformed in the deployment of the stent. So
no, I'm telling you that I'll leave that stent as such. What will happen?
Yeah. We can leave that.
Why you have covered that stent? What are the complications and what are the implications?
I have not covered the stent. I have just post dilated the proximal end of the stent. The proximal end, 6 to 8 mm of proximal end, I have just post dilated that part, and I left the stent as such. I didn't do nothing there.
Okay. You did not cover this one, no?
No. I didn't cover the stent.
Okay.
Nothing.
Now, that was a critical issue. What are the complications that can arise when we leave the stent as such?
Yeah, one the acute or hyperacute issue is stent thrombosis after the stent rupture there. Second one is if you are not post dilating the proximal part or that segment adjacent to the stent, if there is under so later on in there might be neoadjuvant atherosclerosis and stenosis, re-stenosis. So these are the possible complications.
So Dhananjay, I think the case that you shown, any acute occlusion at such a short duration, I think during a stent which was having a problem and you had to dilate it again, post dilate it again with another balloon, and you thought there was a stent deformity. Dissection has to be one of those things which you have to keep in mind for such an acute occlusion. Thrombus at such a short period of time, maybe it was probably within 15-20 minutes.
Yeah.
So a dissection which was not picked up on angiogram was probably one of the reasons. So in this particular setting, that's the reason that imaging is so very important. First of all, to see what happened to your stent, which you saw angiographically on the fluoroscopy. That is the one thing which you have to see and kind of find out exactly what happened. And then the positioning of the proximal balloon, that it does not come out the stent and touch the artery, the naked part of the artery. That is so very important because such a acute cutoff from the proximal portion of the stent dissection is one of the issues which needs to be taken into account.
Taken care of.
It was good that you wired and dotted and it came out, but there was a
Yeah.
possibility that if you did not cover the proximal edge, if it was a dissection, you might actually could have landed up again in the similar problem within a few hours again. What do you
Yes.
think, Dr. Prashant?
Definitely, yes. Dr. Dhananjay,
Sir.
what is the role of imaging in your case? What
Yeah,
image you
definitely.
would prefer?
In a stent rupture, the OCT will be the best one, but I don't have any imaging support.
No, in stent, if the stent you are expecting a stent fracture or stent rupture, I think IVUS is good in comparison to OCT. What do you think, sir?
Yeah, I think, Dr. Prashant, any imaging modality is good enough for me when we're talking about an emergency, I mean, that is one of the things. Because I think if it is a strength related problem, OCT probably has an edge, but IVUS will give you an equivalent picture as well. But OCT will give you a definitely better picture. But also, I think the stent edge section, that is one of the things which will be very well seen on OCT as well. So I think if we do not have imaging routinely in all the cases, but I think we should have exposure in imaging right now for every cath labs, because
Yeah,
at
your
least the
voice is
operators
not.
can
I'm
be
not hearing your
doing
voice.
them at least when they're having problems, if not doing it routinely. So this is a very interesting case where I think imaging could have solved a problem before it happened,
Yes.
because once you saw it angiographically, there was a stent distortion. So you needed to know exactly what happened to the stent. And that is not a matter of speculation. I think it has to be confirmed by imaging, whether it's IVUS or OCT, whichever is available. If you have both, I think OCT is preferred. If you have one, I think whichever you have. I mean, that's my take on this case. I think I'll ask Dr. Soman also to kind of join in. If he, Dr. Behra, you unmute yourself, Dr. Behra. Yeah, you can give your opinion. What do you think?
Yeah, in this case, I think IVUS may give a better view of the stent distortion.
Okay, do you agree that that imaging is very, very important in this
Yes, sir.
case?
Imaging should have been done in the case.
Okay, but unfortunately, that
is not available.
Do not have imaging. But
Yes,
tell me, Dr. Dhananjay, what did you learn from this case? What would you do when you have a similar problem next time? What would you do? Dhananjay? I think he has an internet issue. Prashant, you can tell us what would be your thought process? We have all faced these kind of problems in the labs, acute occlusion.
Definitely. Basically, in case of to avoid stent dissection or stent fracture, we should take the help of imaging. We should calculate the distal diameter of the vessel and take the stent size as per the distal diameter. And depending upon the proximal positioning, we should do the pot. So the basic idea is to take the help of the imaging, because it is a newer area. We should take the help of the imaging to optimize our result, to give the best result for the patients.
Would you have put another stent in this particular case? Proximally?
I would have put one other stent. Definitely, I would have put one other stent in the proximal area, because thrombus, there's chances of less thrombus in the proximal area. The most common complications there is dissection. We should look for the dissection. If we have imaging facility, we would have gone for IVUS or OCT, whichever is available, as you said, sir. And if we don't have imaging, then I would have put one stent there, so that my night I could take the good sleep and the patient as well. What do you say, sir?
I think this is an excellent point which you put. I think if you did not have imaging, and if you have to do a guesswork, I think it is always advisable to take into account that there is a possible dissection, there is a stent fracture or this distortion, it is better to put another stent proximally and to come out a little than what you have put before, so that you are completely covered and you are secured. I think this is a very, very important. I wouldn't just balloon and come out. I think you're probably leaving the same problem again. So that is one point I think which needs to be learned from this case. If you do not have imaging, if you have imaging, I think you can be very precise as to what you will be doing anyway. So I think this is an excellent learning case. Dr. Dhananjay, thank you for letting us into this kind of a case, which is, I thought, was a very, very good one to learn. So we move on to our next presentation and the last for the night. This is Dr. Koman Prasad Behra, who's a consultant interventional cardiologist at Apollo Hospital, Bhubaneswar. And I know that Dr. Behra's center does very, very good cases and they have very good operators as well. So we expect a very good case coming out of Dr. Behra's kitty. And he will be talking about nightmare on the cath lab. And I think we all have faced these nightmares in the cath labs in our careers. So let us see what Dr. Behra is giving us. Over to you, Dr. Behra.
Yeah, thank you, sir. Thank you, sir, for such a warm welcome. Good evening, all my viewers. First of all, before going to my case, I would like to thank the mentor, Dr. P.K. Sahu, who is the operator of this case. Coming to the brief history of the patient, our patient was a 50-year-old gentleman who was a chronic smoker, who was non-diabetic and non-hypertensive, who presented to the emergency ward with just 8 hours duration. On clinical examination, he had stable vitals. ECG showed normal sinus rhythm with ST segment elevation and T inversion in the inferior leads, suggesting an acute inferior wall STEMI. Echo showed regional wall motion abnormalities in inferior wall. The LV and RV function was normal. Patient was taken for primary PCI. Now coming to the angiogram of the patient. Here we can see the LAD is normal, SARC appears normal, and we can see the distal RCA being filled by collaterals from the left system. This is another view showing normally LAD and SARC with distal RCA being filled by collaterals, left system. This we have taken a lateral view in which the distal part of RCA is being seen, and this is the RCA shot showing complete occlusion from proximal segment. Now we planned a strategy. Our strategy was to wire the lesion followed by thrombosuction. Then we planned for a pre-OCT to look for plaque morphology and to determine the size of the stent. Then bed preparation by pre-dilatation if required. Then stenting followed by post-dilatation. Then we planned for a post-OCT for optimization, apposition of the stent and to rule out any complication. Now, based on our plan, wiring of the lesion was done. After wiring also, we can see there is no flow. Then we did a thrombosuction. After thrombosuction, there we found a TIMI3 flow, and there is lesion of 90%, around 90% in the mid part of RCA. Then we did pre-dilatation of the lesion. Then again we did a OCT run of the of RCA, in which we can see the distal part complete, intima media are completely visible. Coming to the OCT video again, we can see the complete, the distal part of RCA appears completely normal. Now this is the lesion part in which we can see fibrocalcific plaque along with dissection is present. as we did balloon dilatation, redilatation. Then proximal part also appears normal. Then analysis of pre-PCI OCT. This is the lesion part in which we can see there is fibrocalcific plaque along with dissection. This is the mid part of the RCA of the lesion, fibrocalcific plaque along with dissection. This is also the proximal part of the lesion in which dissection is noted. Then as per our plan, we stented the RCA with Giant's Expedition 3 into 33 millimeter. This is the stenting. After stenting, we can see there is complete TME3 flow. Then post-stenting angiogram. This is post-stenting OCT. We can see this is the distal part. In the distal part of the stent is completely apposed. This is the mid part of the stent, which shows complete apposition along with good expansion. This is the proximal part of the stent, which also shows good expansion. Then analysis of post-stenting OCT. This is the distal part of the stent, which shows complete apposition and expansion indicated by branch of white dots. This is the mid part of the stent, which also shows the same results. And proximal part of stent, there is complete apposition along with expansion. Now coming to the nightmare. As soon as final shoots were taken after removal of wire, we can see there is 100% RCA occlusion. Rewiring was done immediately and shoots were taken to know what went wrong. After rewiring, we see that there is TME3 flow. Now in the proximal part, we can see there is a small dissection in the osteoproximal part of RCA. Now again we did OCT run. This is the stent part. Which shows complete apposition. Now coming to the proximal part of RCA, osteoproximal part, in which we can see a large dissection flap in present. And coming to analysis of the osteoproximal part of RCA, we can see the dissection flap, which is covering around 180 degrees. Then why the dissection occurred? There is an effect known as the razor effect. In the razor effect, probably during pulling of OCT catheter, the guide catheter gets sucked in, which results in tearing of the intima. This is the intimal tear and creating a false lumen. In this part, the larger lumen in which the wire is present is the true lumen, and this is the false lumen. The type of dissection in our case was type F dissection, as there was complete TME0 flow. Now we plan to stent the osteoproximal part of RCA, which was stented with Giant's Expedition 4 into 15 millimeter. Then we stented the osteoproximal part of RCA. Then we did post dilatation. Then final OCT run. This is the final OCT run. which we took from the mid part of RCA, in which we can see the distal part is fully opposed and good expansion is also good. Now this is the overlapping part of the stent of both the stents, which also shows good expansion. Now this is the proximal part of the first stent, second stent, which shows good apposition. Now coming to analysis of the OCT run. This is the proximal, this is the overlapping part, which shows good apposition indicated by white dots. This is the mid part of the second stent, which shows good apposition. In the osteoproximal part, the stent was not fully opposed, so we did a pot. Now, pre-OCT results. This is the pre-stenting. This is the post-stenting results. Now, lessons learned from our case. Hastily pulling out guide wire with OCT catheter may cause ostial dissection due to guide catheter getting sucked in, which is known as razor effect. Crossing into the true lumen may be challenging. In our case, we were lucky that we could get into the true lumen. Imaging with OCT delineates the cause of closure, extent of dissection, and to plan strategy to tackle the dissection. Thank you.
Thank you, Dr. Behera, for this excellent case. It was actually a very good case where we have a lot of learning points, which is also similar to the previous case shown by Dr. Dhananjay Kumar, where he also had an acute occlusion. So I asked Dr. Prashant Kumar to give his opinion first. Prashant?
Nicely done case. First of all, I would like to congratulate Dr. Somin. That's well done. It's a very nicely done case. And there are very two learning points for the beginners. First is, whenever you go for any case, you should pull the wire, whatever wire it is. It is a normal PTCA wire or OCT wire. You pull the wire with slightly disengagement of the main guiding catheter.
Yes, sir.
And under the fluoroscopy guide view, because you whenever you pull the wire, there's always chances of going guide catheter into the stent, and it will hit the stent, it will deform the stent struts, and there may be dissection. So first learning point is razor effect, what you have explained. And the second important point is there is much role of imaging. You should take the help of imaging in today's practice, because with the help of OCT, you have diagnosed the ostial deformity and proximal dissection of the stent, so that you covered that stent and patient got a very good result. These are the two important learning points. And what do you say, sir?
Yeah, I think these 2 points that you mentioned are very, very important, particularly while we are getting more into secondary procedures, in the sense that we are using guide cats, we are using mother and child catheters, we're using the imaging catheters. So it is not a case of just doing a stent and coming out nowadays. So after stenting, we have a few more procedures which we are doing routinely in many cath labs to make sure that we're optimized. In the particular cases, I think that, as you mentioned, sucking of the guide catheter is very, very important. So either you disengage a little bit of the guide catheter while you are pulling out the wire, or you can actually give a traction on one hand while you are pulling out. And the very, very important part which you mentioned, Prashant, is to do it under fluoroscopic guidance. We cannot afford to do it without that. So I think once the whole procedure is done, that 1 second of miscalculation can create a disaster in the lab, what we have seen. In this particular case, I think there were 2 possible scenarios. One was that there was some plaque in the proximal part of the stent which caused the dissection, and the other one was actually guide catheter induced dissection. So with the imaging in hand, we could actually tell that it was not a proximal stent edge dissection, but it was a guide catheter induced dissection, which could be covered properly. So I think while we are stenting nowadays, and I think immediate things are, as you mentioned, to know what you are doing. And knowing is through actually seeing, and seeing is believing. That's the way I think we should be operating. For medical legal reasons, I think it is very, very important nowadays that we image. But the reality is that actually 20% maybe is in global scenario, only 20% imaging is done. The rest 80% is not done. In European, a lot of European high volume labs, they do not image. They just go on. They say that with experience you can image. So the moral of the story is actually the lesser experience we have, probably it is better to image and know what we are doing. And that is probably one of the best mentors and guides we have is through imaging. So I think these three cases which Dr. Kadir presented, Dr. Dhananjay presented, and Dr. Soman Behra presented were excellent learning cases. I think we always learn, whether we are beginners or we are finishing. And I think Dr. Prashant, you would agree that all the three presenters did an excellent job. And you have your final comments, and then we can close the session.
Thank you, sir. Nicely done case. Nice evening to hear all of you. Thank you. I would like to congratulate all of you. Thank you.
Okay, so Dr. Kadir, Dr. Dhananjay Kumar, and Dr. Shoman Behra, many congratulations for the cases which you do. And I'm sure that each of the sessions, we all are all learning, and wishing you a very, very good evening and have a good night. Thank you.
Thank you, sir.
Thank you, sir. Nice.